Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode. This week on Plenary Session, you're in for a real treat. I've got Ben Mazer, and we're going to talk about a few things that have to do on the interface of social media and the week's news. And I've also got Tem Bendapudi, and we're going to be talking about Caplacizumab, the new drug for TTP. Is it really standard of care? Should it be? Who should decide? You won't want to miss this discussion. And first, I have a bit of a monologue, but I ran out of time, so I won't be able to say all that I think. If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD-MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com. I planned a lengthy monologue, but the week got out of my control. And so I really wanted to talk a little bit about the Scott Atlas censoring moment on Twitter. Twitter, of course, removed a tweet by Scott Atlas where he voiced his view that masks don't work. I think it bothered me not as someone who supports Scott Atlas, but as someone who believes that, the right way to combat speech you disagree with is to argue why you believe it is incorrect. The wrong way is to remove it. And I ended up in a longer discussion with someone who was a big proponent that we should remove these kind of anti-masks or anything that was in any direction other than rah-rah-rah masks. And this person said that, it could lead to bad things happening to people. Well, it turns out every medical controversy proponents believe that it could lead to bad things happening to people. So one other example that I tossed at this person was, what do you think about mammograms? This person said mammograms save lives. I said, oh, really? It's interesting to me. By lives, you mean breast cancer-related mortality? Sure. And then I said, somebody saying that mammograms don't save lives potentially is going to make a woman decide not to do it. That could lower the survival of women in your worldview if you believe that it saves lives. And this person said, yeah. And then just when I was about to lock this person into the trap and ask if they would censor such speech on Twitter, somebody interrupted and I couldn't do it. So I got distracted. But my point is that, of course, mammograms don't save lives. There's no clear evidence in pooled analyses that it lowers all-cause death. And there is a reduction in breast cancer-specific mortality, but for a number of reasons we've discussed on prior episodes of this podcast, that's insufficient. One, there may be miscoding. Two, it doesn't fully capture the off-target effects. So here's a great example, though. People debate. People don't agree. Some people think it saves lives. Some people think it doesn't. If you think it saved lives, of course, any speech to the contrary may cost lives. Similarly, in the mask situation. But the right way to handle that in a scientific and academic setting is to win the war of ideas. It's not to censor your opponent. And paradoxically, I fear that if you delete Scott Atlas's tweet, more people are going to be dragging their feet in the anti-mask camp. It's really going to work against you. Anyway, I can't go on and on. This is supposed to be a longer monologue, but it made me think about something called A Range of Reasonable Views. And this article is coming out, hopefully, by the time you hear this podcast, it'll be out on MedPage today. You should check this article out. It's called A Range of Reasonable Views. And it reminds us that in the age of COVID, nobody knows all the answers. There's no randomized control trial of mask mandates in a politically divided country with a leader who is a former reality TV show star in the midst of a global pandemic where everything shut down. There is no such randomized trial. So all of us have to approach every issue with just a little bit of humility and realize that we may not know all the answers. And in such an environment, maybe we should be willing to hear people who disagree with us a little bit. And maybe if we think we can silence our way to solutions, maybe that's kind of an anti-American idea that's really sort of against a lot of the principles in this country. So read this article, A Range of Ideas, and just consider for a moment that there might be an importance to hearing people out. So on that positive note, we're going to turn to Ben Mazer. You won't want to miss this discussion. I start with a doozy. Let's see how Ben handles it. I'm back in plenary session, joined via Zoom by Dr. Ben Mazer. Dr. Mazer is an instructor in pathology, currently at the Johns Hopkins University. He is a pathologist, and he is someone that will be well known to many people on medical Twitter. He is a very thoughtful commenter, particularly at the intersection of the media, social media, and medicine. Dr. Mazer, it's a pleasure to have you here on the podcast.
Thanks. Yeah. Long-time listener, first-time caller. So it's very nice.
Terrific to have you. So, I follow you with interest over the years, and we have many overlapping areas, which I hope we're going to talk about, particularly cancer screening and overdiagnosis and those sorts of issues. And along those fronts, you wrote sort of an article that I really enjoy about overdiagnosis with Gil Welch and having a month for overdiagnosis. No, that was by you, but you wrote it yourself. A month for overdiagnosis awareness. We'll talk about that. But I'm wondering if we'll start by talking about, is it fair to say, you're a social media guru? Maybe not a guru, but you have some savviness with the platform.
Social media. Yeah. I started using it around when I was discussing things with Dr. Oz in medical school. I was very critical.
Oh, that's right. He was an imbecile. Yeah. He said a lot of stupid shit. Isn't that fair to say? He still does, really.
I've sort of stopped paying attention. Luckily, I presume he still says that. I think he's even become a COVID expert. But
who isn't these days? Who isn't? I've seen a lot of COVID experts on Twitter. But you were part of. Oh, now I remember. I've forgotten this whole Dr. Oz thing. But you pushed hard on him to face some reprimands for the crazy things he was saying.
Well, yeah, I was involved with the AMA. I thought it was a really interesting organization, and I thought they were in a position to kind of take a public stand and sort of help the image of medicine and sort of add some scientific rigor to kind of the way people view us, and say that we'll call out a famous doctor if he's kind of spewing a bunch of nonsense. The medical profession does care about that.
Sure.
But I guess it wasn't a pandemic, and so no one really cared. And it took a year of work, but the AMA did come out with some kind of policy recommendations, for how doctors should speak in the media. I think maybe, some people could be reading them now during COVID, but it's about focusing on your area of expertise, expressing uncertainty. I fought a year to get these things written, and they were very thoughtful guidelines. And then when they came out, a bunch of doctors were like, well, this is so obvious.
Yeah.
I mean, it's so generic. And I was
but they've all been violated now. I mean, talking about your expertise, COVID, that's gone. Expressing uncertainty, COVID, are you kidding me? Get out of here. There's no uncertainty. We know exactly what to do, and we know who's wrong, who are the bad guys, who are the good guys.
Yeah. So, and the other thing was making sure you disclose conflicts of interest. That's become a lot more complicated in the COVID era.
It's a confluence of interest.
Not a lot of people have financial conflicts, but...
Yes. Some people do, actually. They run these consulting firms, and they're doing a couple $1,000 an hour consulting on the side for governments, local municipalities. They don't disclose that. And if you're doing a lot of consulting on how to safely reopen, one would imagine that you have a interest in creating a certain narrative around the risks of reopening. I mean, I think that would be plausible, but we don't have to go there. This is not this. I wasn't taking you in this direction. I was just wanted to say that, you're somebody who I think of is savvy when it comes to social media. You're also younger than me, so I assume people younger than me are more savvy with these things. But you put your foot in.
Not that much younger.
Not that much.
You're pretty young. You're just accomplished.
No, well, that's in the eye of the beholder. Some people would say have done a lot of problematic things. But the reason I said all this complimentary stuff is just to bring up the fact that you put your foot in it recently on social media, and that's what I wanted to talk about.
Oh, jeez.
You tweeted a list of people to follow, Ben Mazer. You tweeted a list of people to follow, and you said, I like to follow these, and I don't know what it was, 10 accounts. And it was, I think, John Mandrola, it was me, it was Venkmurthy, it was some other people. I forget exactly.
I don't actually remember the exact list. I kind of just picked some people.
You picked some,
that I liked.
That's how you got yourself in trouble. Because of the people you picked, like 11 were men and 1 was a woman, something like that.
Yeah, that turned out to be the case, and some people were very critical of that. And I was sorry. I think I was very non-thoughtful in tweeting out the list. I just picked a bunch of people and didn't really give much thought to the composition because I follow 1,000 people on Twitter, and I I like maybe 100 of them. I don't know why I follow the other 900, but I do. But, I like 100 of them, and I picked some people probably that had recently tweeted some things that I liked. And, mostly people who do a lot of writing, whose essays I read, and I don't know. I had some criteria in my head that I didn't actually make explicit. And so I don't know. I mean, I think it was a good lesson that you got to actually be thoughtful about this stuff, although people were quite critical. I got a lot of messages, so.
You're a misogynist, is what you were basically told.
I don't think people use those words, but I think social media is a bit of a minefield, and I don't want to say that those critiques were without merit, because if you're going to start, absolutely, the way people do these things thoughtlessly, they create lists, they pick, the media journalists, they pick people who to interview, for their stories. They just kind of pick who's around or pick who's prominent or pick who their friends recommend. And none of these things are malicious. I mean, all that's like a normal way to go about finding people to talk to or people to promote. But it does show that sort of the structural bias. I mean, that if the first, if you go around and ask your friends who you should talk to for an interview, and they all recommend a bunch of white guys, you'll interview a bunch of white guys, and that just perpetuates the issue. So actually, I do think in that sense, I did put my foot in it, and it does show you have to be thoughtful about these things.
I want to unpack it a little bit with you, because I thought it was so interesting. You apologized, actually, and that's obviously a rookie mistake online. When you apologize, an apology is never good enough to satisfy everybody. It's always going to fall short. I actually think that that's really problematic, because if we don't accept apologies, then people will stop giving apologies. And we have a great example of that in the highest office, a man who has probably never apologized for a thing in his life. But I guess the thing I want to unpack a little bit up with you is, because I think I agree a lot with you about the sort of structural biases that are present in the system. And we can talk about, one way that might manifest itself is if you look at all the CEOs of Fortune 500 companies and you say, boy, they all look the same, right? They're mostly white men. If you look at the deans of universities, if you look at presidents of universities, if you look at department chairs, if you look at the people quoted in the New York Times, that's an institution, the New York Times. And there are these sorts of biases that probably represent the product of lots of different problems in the system. But I think let's come to where you are on this spectrum. You're not the New York Times. You're not Time Magazine. You're just some random person on the internet. No offense, you're somebody who I like, and that's why we're going to talk for the next.
I'm a certified rando.
You're a certified rando. You're a certified rando. You're just a random person on the internet, and you're just tweeting a list, one tweet of just names to follow. You're not picking the department chair. You're not picking the provost. Do you have that obligation to diversify your list of picks? Do you have an obligation even to think twice about it? Somebody pointed out, I think you pointed out, you just hit the @ symbol and these were the names you had interacted with most recently. And somebody said that even that is a problem, right? That's telling. You're interacting with mostly men. But to be honest, you're interacting with, I would say it was certainly multiracial, the list. I mean, it wasn't mostly white men. I think it was probably mostly Indian, children of Indian immigrants like myself. I mean, if there were to be a bias, I think it would be heavily, if there were to be sort of a mismatch, it would be the cardiologist mismatch, too many Indian Americans. How do you think about that? I mean, I'm really curious. Do you have the same obligation as the New York Times in your tweet that you made with 10 seconds of thinking? And that honestly has how much influence in the world? Modicum.
I'm honestly shocked you read this and remember this. This is sort of like ancient internet history. What is this, 2 months ago, 3 months ago?
Yes.
Anyway, I think it was pre-COVID.
It was, yeah. Back when the most offensive thing on the internet pre-COVID was, remember that white guy who said he didn't like Indian food? And they hung him for that. He said he didn't like Indian food, and they got him. That was the worst back then. Now, of course, we have masks and we have all these other things to get angry about. Yeah. But back then, it was he didn't like Indian food.
I think I got a lot of people were critical, but I got a range of ways people were critical, right?
Yes.
There are people that I think followed me and I've interacted with who I don't really know personally, but I've interacted with them on Twitter and I know who they are sort of. And they provided, really thoughtful responses saying like, I'm sure you didn't mean anything by this, but, I think you probably could have been a little more careful or, could have used, your followers to promote, more women. And, I'd just really appreciate if you could be a little more thoughtful, something like that, where, they were pointing out something that was hurtful to them in a way that they were trying to be very respectful. And I'm, I was extremely open to that. And I didn't feel attacked. I didn't feel, you
were open to it.
I felt like they absolutely had the best interests of everyone in mind, and they were going about it in a really careful way.
Do you agree with that, though? Do you agree that it is the duty of every individual person to promote in their narrow sphere of influence social, racial, gender diversity broadly?
I think if you can, you should. I know a lot more women physician. Again, I was focusing mostly on physician writers,
Sure.
Physician women writers who
you could have
be
included.
Promoting. Absolutely.
What about ideological diversity? Do you have a duty to do that?
I do. I don't know. I try not to follow people that I disagree with.
I know.
That's
what I'm trying to. Yeah.
I try to follow between like 1 and 3 people I really disagree with, and then I kind of like hate read their tweets.
Me too.
And then that way it's like only 1 in 100 or 1 in 1,000 tweets is something that you can't stand. And then after a couple months I stop following them. But
let me ask you another question. If I were to go back and follow you like a stalker, and I would see the last 10 people you had dinner with or coffee with, do you think it's equally distributed between men and women?
Well, this would be pre-COVID because I don't have have dinner and coffee with anyone right now. But no, it probably wouldn't be. I don't think so. And I don't know what that means actually. I've never really thought of that.
This is what I'm playing into. I don't know if I have the answers, and I'm really kind of trying to talk it out with you a little bit because, I acknowledge that is a problem. As I stated, for deans, for professorships, for chairs, for so many spheres of life where you want it to look as diverse as everybody. But if you were to look in my phone book, if you were looking at your phone book, am I middle age? I'm 37. Is that middle age or no?
It depends how hard you live your life. You could be halfway over. But
so I hope I'm still young, but I don't know. Middle-aged, straight American man. That's me in a nutshell. Who are children of immigrants. I'm 100% sure that if you took everybody who fit that demographic, that there would be a bias in their phone book, friend circle. They have more male friends than female friends. That's just simply a fact.
I don't know. I'm gay. So growing up, I mostly had women friends because a bunch of straight guys in high school and middle school were not the most progressive,
sure,
open-minded people in the world. And it tended to be women who I could get along with better. Now, as I've gotten older and probably the world, or at least America, has changed,
yes.
I have probably just as many straight guy friends, gay guy friends, straight and gay women friends. It's changed a lot. I think that was just a product of whatever, being an adolescent. So it has changed. I think the problem, some of it depends on your perspective of diversity and representation. And I think I do think about things through the lens of race and gender and sexuality.
Yes.
I think that would be completely ignorant to ignore the power of these things. These are cultural, these are longstanding cultural mechanisms that people have used for oppression. But you also have to think about power structures within medicine, which are kind of its own separate thing. So the only thing that really upset me about this whole ordeal, besides me being embarrassed and feeling bad that I had done something that I wouldn't, if you had asked me would I be this biased and promote mostly men, I would have said no, and then I did it. So it was a little embarrassing. But the thing was when a bunch of, very prominent, tenured physician professors started tweeting at me and being frankly, pretty insulting, not very sensitive to my position. that I didn't know how to react to that. I had a lot of emotions because, if I deserve to be called out, whatever. I mean, I guess I deserve to be called out, but it also felt very strange. I don't think I'd even finished residency yet. I think I was in my last couple months of residency. So I was still technically a resident, although I was on my way out the door. And, these associate and full professors, were, basically saying I'd failed. And this is an example of, white men who, don't promote diversity. And maybe critiques in fact were correct, but it felt very hard to be attacked by people who were more powerful than me in medicine. I didn't know them. They didn't know me. These are not actually even people I'd ever really interacted with on Twitter. I don't know how it got to them, but
somebody pointed out that to me, that are they aware of the fact that this is a gay medical trainee who they are accusing of not being sensitive to know what it's like to be an outsider, when he must deeply know what it's like to be an outsider, because that's never been easy shoes to walk in medicine, which is really historically conservative field.
Yeah, some of that's true, and but I don't want to make it like gay versus women versus racial minority. But I do think the power structures in medicine are real,
yes.
And I'd just gone through med school and residency where you clearly have a hierarchy and. Frankly, social media is kind of a place where the hierarchy breaks down a little usually. Yes. And people, I interact with really prominent physicians and on social media all the time. It's usually a kind of equal footing, or at least they're very receptive to what you have to say. It's not necessarily the same as in sort of the real world hospital setting where you're never supposed to even really ask innocent questions sometimes to your superiors. So I'm used to that kind of social media interaction, but then I guess it's sort of, I wasn't expecting the reverse. I guess I was kind of expecting prominent physicians with a lot of money and power to be a little more respectful to me because I'm a trainee, and maybe, if you're going to criticize me, do it in kind of a pedagogical way, not in a, I'm going to just attack this rando on the internet kind of way.
That's one of the things that I was struck with was, the attacks, you got a lot of pushback, more than I thought was warranted for a tweet that had a shelf life of about 15 seconds. No one's going to
until you brought it up again.
No, well, I'm bringing it out. Yeah, I'm going to keep bringing it up. And then the other thing you mentioned was, and I think this is true, you hit the @ symbol. You typed @ on your in your tweet, and Twitter will prompt you with the accounts you most frequently interacted with. And I think it's possible that you've picked those accounts you've interacted with for all these sort of unconscious bias reasons. It's possible. But when I look at that list, I see a different theme that emerges. There are not many accounts of people in biomedicine who question established medical practices. You're one of them. I think I'm one of them. Vink Murthy's one of them. John Mandrolo is one of them. The people on your list, I think, had an ideological theme. It's a niche market. It's a boutique market. A handful of people who really question medical practices. That was the theme of your tweet. These are the accounts you're interacting with. So I guess one of the pushbacks you got was, why are these the accounts you're interacting with? That itself represents bias. But I wasn't sure that that's the diagnosis. I felt like you're interacting with these accounts because they're talking about a set of issues that you're interested in. It happens to be, in this one case, it happens to be that they're mostly men. That they're mostly Indian men. To be honest with you, the change in population from the average American population to your list, white men are severely underrepresented as a proportion of the population. They're severely underrepresented. Indian men, they're severely, probably 20-fold overrepresented. Women may be underrepresented, of course, and maybe other minority groups may be underrepresented. But I guess I'm really struck by.
They were all straight, by the way, I think. I don't know. I can't really tell on Twitter.
Yeah.
Everyone's a little gay on Twitter, but I think,
I guess.
But I think they're all straight.
I think they're all straight, too. I don't know. Actually, I try not to get too deep into people's personal lives, but that's possible. I guess what I'm trying to articulate is this sentiment that both things can be true. It can be true that institutions And people in positions of power and authority ought to do their best to make sure our faculty, our staff, our research groups are as broad and representative as possible. I believe that. I'm a progressive. I do believe that that's true, and I think that's a deficiency. At the same time, it is possible that every instance that occurs in the world where one, as you say, rando tweets a list, it is possible that every instance that occurs in the world where there is an imbalance in gender or race or sexual orientation or, whatever you want to put there, it's possible that not all of those represent bias. Some of those represent other things that are driving that you may not fully appreciate. And I think if I were to speculate on Twitter, the biggest thing that's hard to put your hands around is the sort of ideas and content that people offer. I think one of the accounts you tweeted was Bartles. You don't know anything about Bartles. You don't know if Bartles is a man or a woman or what.
Oh, yeah. I don't know if I tweeted that one.
I might have been, but I think
I can't even remember. It's
I know.
To be honest, Lisa
don't...
Rosenbaum was the woman. She's a correspondent for the New England Journal of Medicine, and she writes extremely thoughtful essays in the journal.
I guess I want to say something more than that. The theme that unites Lisa Rosenbaum, John Mandrola, myself, it's not that we're thoughtful essayists. There's millions of thoughtful essayists. That's what I want to articulate. There are millions of thoughtful essayists, and that's why I think people were going to fault you a little bit. There are not many people who are commenting, Lisa's one of them, on the intersection of money, medicine, medical decisions, specific medical decisions like stenting or not stenting. There are not many people that fit in that boat. And I think the theme of your little list was that. And so I guess the idea I'm trying to articulate is that if one looks for a perfect distribution in every tweet that exists in the universe, and in the absence of that perfect distribution, assumes that the person is biased, I think that is not, one, it might not be true. I think in this particular case, it is inaccurate. It is not the product of bias. You may be biased for other reasons, I don't know. But this is not the product of bias. It's the product of something else. And two, it's not even desirable. It's not what we should be doing. And then three, I would say it's not productive. It doesn't help the cause. In fact, it's a distraction. It makes people out there who say, when we talk about the need for having leadership in academic medicine be diverse, if they also see that you're trying to enforce that Ben Mazer's tweet is not diverse, there are a lot of people who are going to lose, they're going to fall out of the camp, right? We want to build a consensus. So those are just my thoughts on it. I think the reason it stuck with me, sort of like a pebble in my shoe, was that I did felt you were wronged. I mean, you were a trainee and there were senior people who were, I think sort of inappropriate.
Well, I do think you're right. You can go too far in this and maybe, it was just a thematic, I was just hitting on people that write about certain themes,
exactly.
And so it didn't have bias. But I think actually, these things kind of interact with each other. When I was a kid, I was a huge computer nerd. I was like the youngest person at these like Linux user groups. It was a bunch of like 50-year-olds and me.
Loser.
So, it was a bunch of like mostly
yeah.
50, and I was like 12, but it was like, a bunch of 50-year-old white guys, hippies who love tinkering with computers. And so, but the thing is, and that was, whatever, it was an interest group, right? It was based on our common interest in geeky stuff. But why was it mostly men when I went to this group? And frankly, it's because there is bias. Why were there mostly men, involved in computers and technology? And, was this really geeky group of guys, who were all awkward and whatever, were they frankly not welcoming to women or even outright sexist? There wasn't a good reason why it should be mostly men, but it was. And so I think there was bias. And so you have to ask yourself, whatever, I just picked a bunch of people and I've never done any kind of survey about what the sort of evidence-based medicine community's makeup is. But if it is mostly a certain kind of person and it's not very representative of the rest of medicine at least, you have to wonder if maybe there is something about this community that is driving people away. So actually, it's an interesting combination. I read an article last year that was a bit critical of cancer overdiagnosis and advocates of cancer overdiagnosis. And one of the things in the article, besides, it mostly talked about the evidence for like mammography mostly, and whether mammograms and screening led to cancer overdiagnosis and breast cancer. And, most of it was a discussion of the evidence and this writer fell on one side and I might fall on another side. But then there was a whole section in the article about how it seems like some of the most prominent proponents of evidence-based medicine, dogma or overdiagnosis dogma have gotten into trouble. Either they've had personal problems, social problems, they've gotten into trouble, in academic ways. And it really stuck out with me in this article.
I remember the article. Yeah, go on.
Mostly whatever, a discussion of the evidence that, people really do disagree about, that it put that personal thing in. And even if the facts of their personal case were true, which, I don't remember the details.
I remember very well. Too well.
But should that matter? And I've actually, this is something that's been a pebble in my shoe I've been thinking about, because at first you're like, no, this shouldn't matter. Like if some, asshole says something scientifically accurate, it doesn't completely make the scientifically accurate thing wrong, although they're probably a bad messenger for it. But then you have to think that if this is a very strange community that is full of outcasts and people who maybe start associating with kind of fringe ideas, because there is a non-zero overlap between some so-called, evidence-based medicine hardliners and anti-vaccine people, and now in the COVID era, maybe even some anti-mask people. I mean, these communities aren't completely separate, and
so here's some
fringes,
here's some thoughts I have for you.
Overlap.
Yeah, here's some thoughts I have for you. One, I guess I would say I would define the theme of your list a little different than EBM, which is just a massive sort of space. There's something else. I might be doing a bad job articulating it, but I bet if one were to diagram interactions for years on Twitter, on content, I mean, let me put it to you another way. One can imagine, what if every account on Twitter was just a color, like just red, green, blue, some random color, and just an anonymous name? And so the interactions were 100% separated from the identity of the people who are having interactions. I suspect there would be something about these accounts that you named that they are interacting more often. Because they're not talking about just EBM concepts. They're talking about really, really in the weeds kind of concepts. I mean, I want to say there is a theme to your list. I can't articulate it well. I might be doing a bad job. Okay, then the next thing I want to say, so I guess I would say that, so one of the things that I think some of your critics were missing in this moment was they didn't know that this is a network of people that talk about a bunch of papers, such as the papers Lisa was writing in those years. She hasn't written those same kind of papers, but you remember the 3-part series on conflict of interest and then her paper on why less is more is actually problematic. I think that so it was less is more.
But they were beautifully written. I mean, absolutely. I agree with some of it, disagree with some of it. I thought they were fabulous.
I think that her talent is the artful presentation of the material as a writer. I think that's a talent. I mean, I will give her a lot of credit for that. It's a very artfully presented set of articles. So I would agree with you. And I think that's why it struck such a chord for those of us who disagreed about the technical merits of the argument, was that when you package something so beautifully, it may be seductive to people. And that's why we argued. I mean, if it was something that was poorly written and no one read, we wouldn't have argued. Now let me... So I do think that there was something about your list that didn't have to do with the racial makeup or even the gender makeup of this particular group. The second thing I would say is I do think there's a barrier to entry into this particular group. And I think that barrier is that it's not good for your career. It's really not good for your career to be in this group. You're not going to get promoted. You're going to be pushed out of institutions. You're going to have to find new jobs. It's not going to be easy for you. And then related to that, maybe there are some psychological predispositions that make one the kind of person, some people always ask me, like, what does it take to be a good academic researcher? They're like, you have to be really smart. And I always want to say, like, smart is one thing, but defiant is another personality trait that helps. Because if you really want to question status quo, you have to be a little bit defiant, a little bit stubborn, a little bit, I don't know. I'm trying to wrap my hands around this nebulous thing of, like, being able to say that, like, all you people who believe this, like, I don't see eye to eye with you. And to have the courage to say that, especially now on Twitter, we see that a lot of times a lot of people just don't want to comment. Okay, then the last thing I'd say before I let you have the floor again. You talk about that article where the author of that article alleged that amongst people critical of, I believe it was mammography, the two of those individuals had some sort of unflattering personal story. One of them did something in sort of a semi-professional personal context that was really horrible, like sort of like a 1 in 100-year century flood, like the worst thing you could think about. That was one of them. And the other one did something that was an academic thing that was within the stock and trade of academics that I think to this day he feels differently about than the other people feel. But nevertheless was sort of a professional reprimand. But I think that article cherry-picked those two examples, and there were, there's not many people, but there's still 20 other people in the space who have never done anything personally problematic. And I think that article was using that in a misleading way, because that article, the author of the article, feels strongly that screening should be done and overdiagnosis is overblown. And then the author seized upon the fact that by chance, 2 instances occurred where 2 people were discredited personally, unrelated to the content. And they used that as an opportunity to say that, this whole field is bad. I don't know. I'll let you have the floor. Yeah.
Well, I think, again, I think actually, the interactions between sort of ideological and social communities and these kinds of other issues of representation and diversity, yes. I don't think they're separate, and the beauty of the internet and social media is that you can find a niche community. I mean, there's a lot of people in medicine that are skeptical of one drug or treatment or one screening methodology, yes. or one little thing. I mean, not everyone is a cheerleader. Not everyone is a blind follower. There's a lot of thoughtful, critical people in medicine who can take a evidence-based look at something and see both sides of the argument. I think there's a lot of that. There's not necessarily, though, I think, tons of people who get really passionate about it. Like, I write about these things and I talk about these things and I think about these things because I really care. And I mean, I'm passionate about it. I haven't made any kind of lucrative career out of it. I just care about it. And frankly, I don't think there are a lot of people that care that much, at least not about it as sort of a broad field of study. They may be critical of one thing or another, which is great. I mean, that's all I really ask. I don't want everyone to be some kind of a zealot. So when you have that kind of passion or that interest, the internet's great because you can find these kinds of people. I mean, I got involved in social media because that's where journalists were, and I was, talking to them about Dr. Oz, and then, and I'm a writer and I like talking to journalists, and then I found all these evidence-based medicine people that, I had read some blogs and articles as I was going through my education, but then this was obviously much more interactive, right? I could respond to some of the people whose blogs I'd read, which frankly, when you're like a young guy, is kind of cool.
Yes,
if you really, you can interact with them, and it turns out they're just people.
Right.
And so that was really nice because I found this niche community, and I have been on social media for a few years, and so you're right in that maybe I was just picking out people in this sort of back and forth community of people that are just really passionate about this, and this is the kind of thing
that's what you were doing.
Tweet and write about.
That's what you were doing. I know that's what you were doing. That's my diagnosis. But go on.
But you have to be careful because, yes, you're right. This is generally a non-powerful community in
it's the word, and that's medicine. It's non-powerful. Not only non-powerful. You want to talk about. I mean, I don't want to get into all the sort of personal things that I've endured and others I know, but you put a target on your back. You joined this community, the community of people who want to say that something and a lot of things are just not helping people. You put a target on your back. Go on. I interrupted you.
Yeah. So, I do agree with you. I mean, I think the majority of responses I personally get when I talk about these things I'm passionate about is that people don't care.
Yes.
They're just apathetic, which is fine, But in some sense, you have to look at both sides. This isn't also a powerless community. This is a bunch of physicians. Some of these people have achieved very prominent positions, and so I had this one reply guy who used to reply to every one of my tweets with just hating it. Every article I wrote, he read it, and then he didn't like it, and then he told me he didn't like it, and no one has to like everything I write.
I know,
but it was just
go out of your way to tell me every
right by the
fucking
fifth
time,
or sixth or seventh article you've read of mine that you don't like, you should probably just stop reading them because you don't like what I write, and I totally respect that. Anyway, but it's fine. I also don't want to be in a bubble where no one criticizes me. A lot of my writing isn't great, but So, and at one point, this random guy referred to me as, just a Medscape writer. Like, oh, I don't listen to Medscape writers. I don't take their opinions seriously. And it's like, because I write some articles for Medscape.
Don't tell me he became a Medscape writer. No, just
I'm also a physician, and I read,
course.
and whatever. I mean, I'm not very important, but I'm also not a lay person. I do have some medical expertise here.
So you say.
And so-called medical expertise.
So-called.
And, but I was thinking about it, and I was like, well, people do read Medscape. I mean, not tons of people read my writing, but it's not zero people. I'm not writing in my diary.
More than academic articles, for damn sure. Go on, yeah.
And then, people read my tweets. I am shocked sometimes. I tweet out random things, and then someone, mentions it later, and I was like, I'm honestly shocked someone read it. I don't know why, but it's actually still surprising to me. Like, you brought this thing up that I hadn't thought about in months, and I was like, the internet's supposed to be fake. It's not supposed to be real. Like two real human beings are not supposed to be talking about what goes on the internet. It's terrifying. And so you have to actually respect that maybe there is some influence in this already niche community. And if we have too much of a chip on our shoulder and we think we're the victims, we're going to also be keeping people out. We're not gonna build up allies in our own fight, but then we're also just gonna we're gonna be biased, frankly. We're not gonna be open and let, people from diverse viewpoints and backgrounds come in. One example is Wikipedia, right, which is now extremely important in sort of the social media and internet ecosystem. But it was for a very long time and still is, a bunch of computer geeks writing these articles and editing these articles and managing it. And
mostly white men.
Probably, yeah.
Probably.
And, and they've sort of built up this niche community, and who really cares? These are not actually powerful, rich people, in traditional institutions, right? But now they're really biased. And, everyone's been complaining that women can't get writing in, they can't get articles about women in, and I think there's tons and tons of legitimacy to this.
Mm-hmm.
People would rather write about Pokemon and video game characters on Wikipedia than, female prime ministers of countries, right?
No, but I 100% agree with that. And the platform is different than Ben Mazer's tweet. 100% agree with the New York Times quoting diverse sources, that sort of thing. One of the things you alluded to is the barriers to entry. And I guess, it sort of irritates me to some degree when people talk to me about this issue. And I'm like, just look at my last 100 papers and look who the first authors are. Just count them up. Look who I'm actually spending my time with, a lot of my time with, trying to help, or at least bring into this field. Maybe they don't always stay. I can't keep someone in, against their will, but I can try to bring in people. But if you look at my first authors, I bet they're more women than men and as diverse as America, or at least as diverse as the medical school classrooms. I mean, I'm trying my best to work with everyone who comes in my door. But let me ask you this. We talk about communities. Isn't there a community online on Twitter? And the community and the topic area is to point out things like you as problem. You're the problem. The community, the thing they care about, the thing that their uniting thing of their community is that every week we got to find someone and pull them up by the collar and show them to everyone and say, this is the problem. And that's a community too. And they're thirsty to find examples. And when you run out of the examples that we could talk about, you get to Ben Mazer's tweet. What do you think? Is that a community or no? And after this, we're going to talk about overdiagnosis. Yeah.
There's definitely people who care about this stuff, but I think someone pointed out to me recently that I seem to have a very strong professional identity. Whatever. I have an identity as a gay man. I have an identity as a Jewish guy. I have identity as a lot of things. But
right.
At least what I present myself, and I do think I actually, a deep part of me, I have a really strong identity of being a physician and being a pathologist. And someone pointed out to me, and it took me back because I hadn't really thought about it very consciously, but it is true. And some of it probably comes from being a young physician, right?
Yes.
I'm new to this. I'm slightly less jaded. And then also I've just spent a decade of my life, working nonstop toward this one thing. Right. So obviously
you're in the phase where carrying the pager is still cool. Yeah. You're in that phase.
Right. Yeah. So, some of it is age, and then maybe some of it's because I'm really passionate about medicine and pathology. So, but I didn't think about it as like an identity, until he pointed it out. And so maybe that's what it is. And so, when I see all these people interacting on these topics and going after each other on social media, and I see that it's a lot of physicians, medical students, other allied health professionals. I mean, people in the medical and healthcare field, and then, other kind of academics and PhDs. I wonder if we're maybe putting the professional identity too far into the backseat. That actually, I think, is something important that unites us. That we're all physicians, or we're all in the medical field, and there is a certain amount of respect we could give each other and thoughtfulness we could give each other, and a way of communicating. We went through a lot of the same experiences, even pathology and internal medicine. I mean, we all went through medical school and all the tribulations that had.
We've both been to war together. We've been in the same war. Yeah.
Yeah. So, and we need to stay, the profession needs to be able to communicate with each other, because it is important for progress in medicine to not have a balkanized profession, to have whatever. There's liberal doctors and conservative doctors and, doctors in a million different specialties in private practice and academic. But for whatever reason, I think there needs to be an undercurrent of professional identity.
I agree.
That sort of lets the small things slide. And man, I mean, I tweeted something about that, before that, getting involved in politics and medicine is complicated. And I think, putting your identity as a physician first is actually, that's more toward, you can get involved in politics, but
if you said that today, they'd be coming after you for saying that. Remember, Mandrola said something similarly recently, and he got in hell of trouble.
Yeah, and it's not a clean line, right? I mean, I have personal political views about all sorts of things,
course,
which I'm proud of, and I'm happy to talk about. Maybe not to patients or anything, but I'm happy to talk about it to other people. But then, when it comes to sort of political advocacy, I tend to focus more on things that I think, in my opinion, directly relate to healthcare systems, health insurance access, things related to lab testing. So whatever, that professional identity. And so when you get these huge pile-ons about social issues or political issues that aren't directly related to medicine, I think we lose a bit of that professional solidarity. And it makes me feel like people, think I'm like an old man for saying these things. I don't know that, what is even professional identity in medicine anymore, because we're all so divided. But I haven't lost faith in it yet.
My last thoughts, I agree 100% with you, and then we're going to switch topics because I don't want to keep making you squirm a little bit. But I guess what I want to say is that there are these structural problems. They're massive. They are deeply problematic. They're the most problematic for real positions of power that are guarded by real institutions. They're the least problematic for rando tweets by rando trainee. There's a gradient. When it comes to education and the pipeline problem we have for underrepresented minorities and in education, there's a huge problem. The problem is worse in pre-K and K. That's where the worst problem is. That's where the pipeline, early life interventions, the real, I think it's much more important. You got to build a pipeline at the beginning. The forces on Twitter that amplify themselves, one of those forces is to find the weekly Ben Mazer and pile on him. That's just a thing to do. It's a thing that gets you more followers and allows you to talk and feel good about yourself, making the world a better place. But Ben Mazer's tweet in the grand hierarchy of injustice is the least injustice in the world. The most injustice is, I would argue, right now what we're doing with kids' school. We have private schools open and public schools for poor black kids are closed. Public schools for poor kids, minority kids, they're disproportionately closed. It's easy to fight the fight where you view the barrier, you view the problem is, I'm an associate professor. Why am I not a full professor? I'm a full professor. Why am I not chair? Why am I not dean? It's easy to fight that fight. It's salient to you. It's harder to fight the fight of, why are these kids not getting opportunities to go into kindergarten? Just in the broad scheme of things. And I think it's easy to find a progressive physician like you and make him feel bad and to show him as an example. It's hard to change the mind of somebody on the fence or who is conservative. I think that's where we would actually make more progress. And so, I don't know, just to close on this, I think I didn't like what happened to you. I didn't like this response. I thought it was a harmless tweet. And it wasn't, and I think people who criticize you didn't really understand why those names were the names that popped up on your browser. And I don't think they were popping up because of their race or ethnicity. I think they were popping up because they happened to self-select into this weird cohort of people who have a deficiency of fear, a deficiency of self-preservation, because that's why they're doing this, talking about this. They have certain types of analytic intellect. They have certain life experiences, particularly medical experiences, that have made them doubt, I think, a lot of medical technology. And this random constellation of things that has hit both men and women, Lisa, John, Indian Americans, myself, and a lot of people. It's just this random thing that has happened. Anyway, I'll move that aside. I want to talk about your new article, The Lottery. This is such a good article.
Thanks.
I'll let you introduce it. Well, actually, let me summarize it, then you introduce it. I always like to summarize it first.
You're much more articulate.
I guess, because I want to know what I get wrong. Here's how I would summarize it. I would say, you have stood by and reflected from the vantage of the way in which we select applicants for the numerous positions in medicine, from medical school to residency to fellowship. And at every juncture, you view it as, to some degree, capricious, some degree popularity contest, some degree irrational, because to some degree, many, many applicants are really good. They have really solid test scores. The difference from a solid test score to a great test score, that's debatable. But these are people who, they know how to memorize things. They can learn things, They're solid. They have solid grades. They've been able to get good grades. They've been able to, show that they care about classwork, and they do that. And the difference between good grades and exceptional grades, that's also kind of, who gives a shit? That's really not much difference there. They care about the world. They all have done some altruistic thing. They all have done some research. They're all checking off all the boxes. And once you get past those filters, if you want to choose Ben over Sarah or Vinayak over Venk, if you want to choose people in this way, to some degree, what you're doing is really just articulating your rando preferences about the world. You like that this guy learned Mandarin, or this girl worked in Costa Rica, and you don't like that Ben worked in Portugal. It's just really random preferences about where he did a study abroad, or those sorts of things. And so your article comes into this space, and you say it is more ethical, it is more logical, it's more reasonable to just draw a cutoff and say all these people who have applied, this 40%, they're all acceptable people. They're people we can train to be good doctors. And the way we're going to pick our class of X is just randomly pick them, lottery. And you think that's better and fairer than the capricious way that we have now?
Yeah, that is accurate. And, you have to think what admissions is for. Who is it designed to serve, and who does it help and who does it hurt? And in medicine, at least, we care about patients, and we want the best doctors to treat patients the best we can. And I think you start from the position that we don't really know who does that. We still don't know how to evaluate doctors and decide
who's better, right? Yeah,
who's a better doctor. Just taking people who are already doctors and saying, and there were a series of articles that came out, that prompted me to think about this, natural experiments and things, looking at different characteristics of physicians and seeing what the actual outcome was, based on medical record reviews and things. You could look at mortality, you could look at other hard outcomes. And I was like, well, can you really measure the effect of a doctor on these kinds of hard outcomes? And then what about the soft outcomes? Because that also matters. Obviously, you don't want to hurt anyone and shorten their life expectancy, but you also want a doctor who's a good communicator and who is compassionate. And I have no idea how to measure those things. I don't know who does. So then, okay, we don't know who the best doctors are in the sense of treating the patients the best. So take a step back. Then how do we decide who to admit to medical school? Is it the people that are most likely to graduate? Because we want people to graduate, right? Obviously, having tons of people fail out and struggle in school is bad for the school. It's bad for the applicants. You don't want people struggling and, not being able to handle the work. So that's sort of a surrogate marker, but reasonable, that you want people to graduate from medical school. But then that, and I was thinking, I was like, well, 100% graduation rate is actually kind of a bad goal in a sense. We're very close to 100% graduation rate in the U.S., right? Yeah. I think
you can be a doctor being terrible all the way there and committing malpractice for years, and it's really hard to get rid of those people. Yeah.
Yeah, but it's not just that. It's also, I think,
preference.
that we've selected a very specific type of person because we're risk averse and we don't want people failing out. So we've selected these cookie cutter kind of people who we know are most likely to graduate. I don't know what kind of doctor they become, but they're most likely to succeed in the medical school environment. And
Can I add? That's also why there's so few people in your tweet. That's also why. Because we've picked people that are risk averse and saying the sorts of things that Lisa, John, they're on different sides of the spectrum, but saying those things that Lisa has said, that John has said, that Venk has said, that I have said, that you have said, that's taking risk. And the people that we're not selecting for those personality traits. Okay, go on. You're right. We're selecting risk averse people. Yeah.
Yeah. So I was thinking, well, maybe 100% graduation rate is actually a kind of failure, because you think about it like doing a medical test. If everybody you test is positive, you're not doing enough tests, right? I mean, you're not expanding your outreach enough that you're getting the atypical cases, that you're getting the unusual or mild cases, right? You don't want everybody you do a medical test on to be positive, because means you're actually missing a lot of positives, and you're missing the subtle and atypical cases, and they're going to come up later, And so in the same way, I think, if you're not taking any risks, you're missing out on people that may not look perfect on paper, but would actually be very successful physicians, And the lottery is a way to open that up a little in hopefully a way that's a little more palatable, and doesn't have as much bias to it. To say that, okay, people with straight A's maybe graduate at a 99% rate, and if you take people with some B's, only 90% of them may graduate, and you may have 10% dropping out, and that sounds bad at first, but think of it from the reverse. If you reject everyone who has a B or lower, 90% of those people would have been just fine. Exactly. And you were actually not letting them in. And is that fair just for that 10%? Just for, these may be real statistical correlations. And that's actually what some of these lottery experiments in other countries have found is, it's a real correlation, right? The higher you achieve academically, the higher chance you have of achieving in a medical education, which is a very challenging scholastic kind of environment. But still, even the people with good but not superlative grades mostly graduate and do fine. And so this is a way to bring them into the fold. And then you have to look even farther back to say, who are these admissions people helping? And this is the other thing that I think people don't tend to focus on, is the people who are rejected. Most people who apply to medical school in the United States do not get accepted anywhere. And then in an individual school, the vast majority, acceptance rates can range from like 2 to 10%. So you're talking about rejecting at any individual school, 90 or 95 or 98% of people. And certainly, people must admit that a lot of those people are probably perfectly qualified, and we just don't have enough spots. And so no one really focuses on them. They're like, but it's sort of the same thing with overdiagnosis. Like, focus on the people that are kind of invisible in your system, in the pipeline. And if the majority of people are getting rejected, you also want to be fair to them. You don't want them to waste their time and money just to have them fail. Because if we could have a crystal ball and know in advance who was going to not get accepted or not, you could say anything those people do to not get accepted, if they're not getting accepted, is a waste. It's a waste of time and money. And so making them go through the pre-med curriculum, making them apply to medical school, it's expensive, making them do all these activities that they think it's going to help their resume to get in. If ultimately they get rejected from everywhere, they don't get into anywhere, which is the majority of people, they've just wasted. And it's human capital that's a huge waste for society, right? Why would we want people to waste their time pursuing a career they can't achieve for whatever reason? That's a waste for everyone.
Let me put it to you this way. So imagine 100 people I've assembled. They've been rejected 4 years in a row, and they finally threw in the towel. They've been pan-rejected 4 years in a row. You would not be surprised if, of these 100 people I've rejected 4 years in a row, from all the medical schools they applied to, let's say 70 plus, maybe more, that if I took them all and I put them in a med school, maybe 70% would actually become good doctors. They could make it 70%. The numbers you've quoted are a little bit higher than that, but those are people who got in somewhere, right? So let's say 70%, 60%. That wouldn't be that surprising, that more than half actually could become a doctor, and a good doctor at that. Would you agree that that's fair to say?
Oh, yeah. A lot of the people that get rejected, absolutely. I know lots of people that got rejected that went to the same good schools I went to, had good grades, impressive extracurriculars, worked hard. I don't know. I don't know what happened, honestly.
Exactly. I guess what we're saying is, we have a system in place where even though you have a 60, 70% chance of becoming a good doctor if we were to take you into school, we're saying that you don't even deserve that shot. That to me is, it is crazy. It seems like, it's not like there's like a 2% chance you're going to make it. You know, we always watch these movies in Hollywood where it's like the guy had a 1% chance of doing it and he, against all the odds, triumphs. Here we're saying the odds are in your favor, buddy. The odds are in your favor and you don't even get a shot. And I think some of the imbalances, and I view it, 22,000 U.S. medical graduates, 30,000 residency spots, a gap of 9,000. That's a huge gap, and I think that gap should be closed. And one of the ways to close the gap is that the people who are currently being rejected, most of whom could actually become good doctors, you know, have some opportunity. There should be expanded medical school slots. I don't know if that ties into you.
You could add a lottery. I mean, you know, I guess I was mostly talking about replacing systems
you're
with
right.
lotteries.
Yeah, replacing it.
But you could add a lottery. You could take what we have as the current system and then say, well, we're going to increase enrollment in every school by 10%.
Yes.
And that's going to be, we're going to, you know, pick of the people we rejected, we're going to take, you know, scholastically the top half of them,
yes.
and we're going to put them in a lottery
yes.
and offer them admission. You could do that, you know, but the thing with the lottery is, you know, and some people pointed out online when the article came out a couple days ago that, you know, maybe the outcome isn't necessarily better. I don't know. They said some math I don't understand, but the outcome may not necessarily be better. You may not select better people this way. And so then what's the point? But the point is that if you know there's a lottery, if it's transparent, you waste less time on marginal things. Like if I know I have the grades and whatever prerequisites to get into the lottery, you know, at least, you know, economic rational person, you know, which some of us think sometimes, you know, you say, well, I'm not going to, why waste any more effort, right? I'm going to get into the lottery and then fate is going to decide. So I'm not going to do that extra, you know, bullshit project or, you know, spend money on a review course just to get a slightly higher grade, even though I know my grade will make it. You know, and so you think about, you know, you're still going to have a lot of people rejected from the lottery. I mean, there's just a limited number of spots. A lot of people want to be doctors. I don't know why, but they do. And so you're still going to have a lot of people rejected. So that is, you're going to have a lot of disappointed people. I mean, but they will have hopefully wasted less money and effort and time through this process. So it's still a net gain.
A lottery is, I don't know, I'm so biased. I mean, I think that a lottery is more ethical than the current system and is more valuable, as you say. The moment you qualify for the lottery, you do not have to do any more useless bullshit to polish your CV. And if anyone disagrees that people are doing useless bullshit, I think they haven't read enough CVs, because people are. CVs are a collection of bullshit that people don't want to do. And I guess I want to say, I mean, a little bit, to push this a little bit, you know, it is really stupid that, I mean, I just think it's just so stupid. It's like, you want to be a doctor. What should you do this summer in your freshman year of college? You should work in someone's lab. Well, that's really stupid. The alternative is you could go to Spain and France and spend 7 weeks there with your friends and maybe take some classes in French or just explore. I think that would be better for your soul, for your life to do that. But the reason that everyone is doing all this, and I don't even think, I want to articulate what's actually going on right now. From the moment people are in high school, every ounce of free time is being taken away from these kids to calculatively do what it takes to build up the CV. There are applicants for medical school with publications, many publications. There are applicants for residency with even more publications. I've seen fellowship applicants with patents. Like, I don't got any patents. It's an arms race. It's just growing and growing. And the reason it's growing is because everyone thinks that these things will get you that edge. But if in your world, you draw the line, and the line is going to be much lower than the current bar, I think, for like the most excellent applicants. You draw the line and you say, this is the bar you have to clear. And maybe different schools could have different lines, right? Or all the elite top 20 schools can get together and say, this is our line. And then the top, you know, whatever, the rest, the 106, the 40 other schools can say, this is our line. And once applicants clear that, then they can get on with being a youth, get on with doing all those things youths do.
Yeah, you know, some of this maybe is just personal reflection because I'm in these sort of career transition. And I think you're right, is that I wasn't really a typical applicant. And And so I see exactly what you're talking about. I think everyone recognizes the arms race that's going on and sort of the stereotypical things you're supposed to do to get into medical school. And, I'm smart and my grades were okay. They weren't great. They were much lower than probably the average medical school accepted person. But my interests weren't necessarily some of the standard things that people do, like, biomedical research, lab research. I never wanted to do that. I care about evidence-based medicine, but that's reading papers, analyzing papers, yes. Statistics. It's just, a lot of people do both, but I just don't care about, frankly, lab research. And so you say, summer your freshman year of college, you got to go work in a lab. That's true. Most of my classmates, I went to Swarthmore College, a small liberal arts college with very high medical school acceptance rate. That's why I went, because I wanted to be a doctor. And I said, well, everyone gets in, so I'll just go here. But then I saw people were doing all this kind of research. And then I realized, like, a lot of people get in because their parents are doctors and they come from a lot of money. I was such an 18-year-old. I was like, all these people seem to like be able to do all these things and they don't need a paying job. And it's like, how do they do that? And eventually I was probably 22 when it clicked. Oh, they're like rich. But, the summer after my freshman year, I worked for this organization called Food Not Bombs that, it's just like sort of community, non-hierarchical organization that provides food to homeless people. And I was in Philadelphia, where I'm from. And so we cooked, vegetarian food for homeless people. Sort of this, it's such an 18-year-old thing. Anyway, I guess I was 19, such a 19-year-old thing. But, whatever. I got to spend time in the city. I love Philadelphia, and I got to meet a lot of people that were very passionate about social activism and sort of doing things, not just talking about it and whatever. We made some food and we fed some people. It didn't change the world. People were still hungry the next day. Whereas like a lot of my classmates were starting nonprofits to feed people in other countries or they were doing all this really impressive lab research. And so that's not really much of I don't know, you can't really put volunteered for some organization, that's not even like a real organization. Like they just have like a listserv, on your CV, and I didn't have any research. And then my grades weren't that great. I did very poorly in organic chemistry, which turns out you don't need to be a doctor. I haven't, pathologists run chemistry labs, and I still don't know any chemistry.
You've read Gatsby, The Great Gatsby. Yeah. And you've read Mysteries of Pittsburgh by Michael Chabon?
I haven't read that, no.
I think he wrote it when he was 22, 24. The summer after my freshman year in college, I went to Michigan State, and I went home for the summer. And I think I worked some odd jobs, but I don't think I did anything. And I hung out with friends, and someday if I were to write a novel about what happened that summer, it would be a novel like Mysteries of Pittsburgh. I could write that novel. But what it's like to be, I don't know, how old was I? 19? 19 years old, hanging out with friends in the summertime in the suburbs of Chicago, distant suburbs, going to some house parties, going to things like that. There's something to be said for that. That's like literally what it means to be young and it doesn't go on a CV at all. There's no place on the CV for it.
No, and I don't want to make it sound like people that worked in labs couldn't have fun.
No, but I'm sure,
some people are really boring, and some people had very active social lives. I was a huge geek. I can't say I had the most exciting social life, but I had friends, and could still do lab research and get straight A's and do all these things. But it's more that are they doing the thing they're really passionate about? And I know people that are passionate about biomedical research and became physician scientists, MD, PhDs, grant funded, and they absolutely love it. It's not about getting ahead in their career, but so and then I ended up applying through this special program. I realized the MCAT was really hard and had a lot of physics and chemistry, and I wasn't very good at physics and chemistry. I was, I liked biology. I was also studying linguistics. I liked that. I liked reading novels. Whatever. So I was like, I'm not going to do well on this exam. And University of Rochester, where I went to medical school, they had this special program you apply at the end of your sophomore year, if you come from certain schools. So I applied, and my grades, slightly made it over the threshold to get into to just apply to the program. And I went and I did an interview, and I really wanted to be a primary care physician. That's what I wanted to do. It was my dream, and so I talked all about how I wanted to be a primary care physician. And then they asked me why I did so poorly in organic chemistry during the interview. And I came with something about how, I don't know, I'm not very good at it. And I was very caught off guard. I don't remember exactly what I said. I was like, I'm not very good at it. And for some reason, they accepted me. I don't know why. And so
Where'd you go to medical school? I don't remember.
University of Rochester in upstate New York. Yeah. It's a very nice school. And they were basically trying to get a lot of more liberal arts people in. It was this small program. And so they were going to liberal arts colleges and saying, well, you don't even have to, be a science major. Just come interview. And so I was really lucky. And, even getting into Swarthmore, I felt really lucky. Like I'd hit a lottery. I had a really good friend in high school who applied also with me. It's outside of Philly, so there were a bunch of people that apply from the Philly area schools. And, she was a much better student. She was in the orchestra. She wanted to be an engineer. Much smarter than me and much more personable, frankly. And we both applied. And for whatever reason, she didn't get in. And I did, and we talked to each other on the phone. We got our letters on the same day, and it was like a complete shock to me. I was shocked I got in, and I was shocked she didn't get in. And she went on to be extraordinarily successful, and, it was absolutely Swarthmore's loss. And it frankly, it felt like a lottery. I have no idea what the decision-making process was like for them. But, and so then it felt like a lottery when I got into medical school. Like I didn't do these typical things. I didn't apply to a typical program. I never took the MCAT. Like maybe it's a bit of imposter syndrome. Like I didn't even deserve to be there. But, so it's felt like a lottery all along. And then, I came along to be a primary care doctor. And actually I applied for the National Health Service Corps, which, they pay for medical school and, because I couldn't pay for medical school otherwise except with loans. And you have to be a primary care doctor. And I was rejected, because I don't know why I was rejected, but I was rejected. And so then I have to just pay for medical school and I can do whatever I want. And I was still planning to be a primary care doctor, but then I fell in love with pathology. I didn't know what pathology was when I started medical school. Right. Who does? Right. I don't know. Right. And I just started to really love it. And then I ended up as a pathologist. And it's like, that's such a serendipitous thing. And, if I'd been accepted to this really great program that would have paid for my medical school and done all these, maybe I would have been happy as a primary care doctor too. I don't want to say I wouldn't. I enjoyed it, but, I would have had a very different career. So, totally random that I ended up a pathologist, frankly. And, maybe if I didn't have a good pathology course in medical school, I wouldn't have even known anything about this field because I certainly didn't even know the word pathology before starting medical school. So it's just been a series of serendipitous events. And, I don't want to be too humble. I'm not an idiot, and I'm very passionate about a lot of things. But it doesn't feel like this was some merit-based process. I feel like I got lucky, and anything could have failed along the way. And so, why not be transparent about that and give people the rules of the game? Yeah. So it's a bit personal. I don't know if that the math adds up to all that, but it feel I feel it. I feel like we could be doing this in a more transparent way because it's already feels like a lottery to me.
Yes.
I've gotten so lucky.
It is a lottery. I think that's what people don't realize. The problem with the lottery is instead of rolling a dice or spinning a wheel, the lottery defining aspects are the randomness of the composition of the faculty members who are present during the admissions committee meetings. And these are not a diverse collection of faculty members. Actually, if we want to talk about representation and diversity, it's a collection of faculty members who are predominantly, I think, in internal medicine subspecialties, particularly primary care, or internal medicine or medical education, which is a very unique type of faculty member. Maybe there's one person or two people who are speaking to demand. They're physician scientists in the mix, but, it's a very sort of narrow section of people. And they can anchor to all sorts of things that are just really random things that people have done or random comments from a certain letter to the editor or an admission essay. And so I think sort of a fully transparent and open lottery would make much more sense. And I guess, I know our time's about to end. I guess I would just say, in my experience was, I chose my college because I went there on full scholarship. So I didn't want to have any debt when I graduated college. And I wasn't going to get funding from my parents to do that. So that's why I chose where I went for college. And when I went for medical school, it was rolling admissions. And I remember very early on in the process, something like October, I got an admission from like one of my top 5 choices. And so I canceled a lot of interviews, but I still went to a few others to kind of explore. And one of the ones I went to, I think this was the Harvard Medical School New Pathway. And the person who interviewed me there said, I'm looking at your CV and you haven't volunteered enough with doctors. And he says, I'm not sure that you know what it means to be a doctor. I'm not sure you're going to be ready to be a doctor. And I told him, I've already received admission from one medical school and I have decided I want to do it. So it is a moot point, actually, whether or not I will be a doctor. That's inevitable. The only question is whether or not I will be a doctor here. That's the question you face. And he didn't like that. He didn't like that answer. I wonder why. He didn't like that answer. And I had a similar experience when I was interviewing many years later for residency at Stanford. And the program director was like, before we start, I have to ask you a series of questions. Tell me about a difficult situation you faced in your life and how you overcame it. What is your strengths and your weaknesses? And those sorts of boilerplate questions. And then I said something like, I'm happy to answer the questions, but I just want to let you know, the reason you're asking those questions is you want to decide who's going to be a good intern here, I would assume, who's going to be a good resident here. And I guess, although those questions have not been explicitly studied to my knowledge for that particular purpose, they have been studied for selecting people for jobs. And it turns out that if you compare first-year job performance reviews at the end of the year to the way in which someone answers those questions, the correlation coefficients are so ridiculously poor that asking your question is almost no better than a coin flip. And he didn't like that answer. I don't know why.
And you didn't do your residency at Stanford.
I didn't do my residency at Stanford.
Well, some of it is plausible deniability, right? I mean, it's the idea. It's a way to internalize, a meritocracy idea, because everyone recognizes that this is not a perfect system that always produces the perfect outcome. I mean, no matter how much of an advocate you are for any kind of educational admissions process, no one thinks any of them are some kind of ideal, perfect thing.
Yes.
But it does provide some plausible deniability for both the applicant and the admissions person to say that, well, there was a reason it couldn't have been completely random, because, well, I got rejected and my friend got accepted, but, their GPA was a 3.8 and mine was a 3.7, so they were the better candidate, and so they got in. And it's like, yeah, I mean, maybe that didn't even really matter, and maybe that's not even why one was selected versus the other. There was some other random reason. But, you internalize it. You say, well, and that's the thing in these kinds of arms races is there's always someone better. So you'll say, well, I didn't have a 4 GPA. I didn't have this extracurricular.
That's like the NBA saying this basketball player is 6'10" and this is 6'8". The 6'10" player is going to be better than the 6'8" player, don't you know? I mean, at some point, it's like, no, they're both sufficiently tall to play in this league, and you have no clue who's going to be better, right? Yeah,
we don't like that's why I told the essay, accepting randomness, because there's already a randomness, and it's very hard to accept. And I think even people that can recognize this at a logical level have a hard time admitting that something important in their life was based on chance. That even if we're going to blame ourselves, and I have plenty of guilt and all these things I've done wrong and could have done better, it's just, I think people would even rather blame themselves than admit that it was just a stroke of bad luck.
Yes.
Because in theory, you can do something about a flaw, right? Like, I didn't score high enough, I wasn't smart enough, or I didn't do this extracurricular, or I didn't perform well in the interview. There's still an optimism to that to say I could do better next time, or I can improve this about myself. If it's just chance, you're just like stuck. And, and that's what has hurt, like, the system, the Dutch system I wrote about, is over. They stopped their lottery after decades, and it was a very successful few decades. I mean, overall it worked very well, but they stopped it because there were just a few people who got into the news that they thought these people deserved to get in. They had great grades. They were very personable. They had great extracurricular. They worked in labs. I mean, I guess this is an international thing. And they got rejected. And so the system is just, and there's nothing they can do about it.
Right.
Like, they already had great grades. They got into the lottery. It was just bad luck. And the Dutch system was a weighted lottery. So if you had the best grades, you had an 80% chance roughly of getting in.
Right.
And this one person who, got in the news and ended up leading to the long-term demise of the lottery, she got rejected you could apply multiple years in a row. She got rejected 3 times in a row. So 80% chance of acceptance each time. 3 times in a row is actually pretty bad odds. I mean, she got very unlucky, right?
Yes.
I mean, you should have, being in the top category each time and still getting rejected is 3 times in a row. It's very low odds. And
Yes.
the only explanation.
1 minus 0.8 to the third power. Yeah.
Right.
Yes.
The only explanation was she was unlucky, and apparently that was psychologically very hard for people.
So, if people.
Because she deserved it.
Yeah.
And she did, probably. I mean, she sounded like a great candidate.
Well, I think there's a simple way to sort out this question, which is, even within a school, they can take their class of 160 and divide it into 2 halves. Half the applications you put in pile A, half the applications you put in pile B. Pile B, you do the lottery method. Pile A, you do it the old-fashioned way, wasting 1,000 hours of conference time to discuss everyone's candidacy. And then after 5 years, don't tell who's who. Don't tell the people you invite who's who. And then after 5 years, you see how often did they pass clerkships, how often did they pass whatever stupid step exam they have to jump through, and how often did they, go into practice, what specialties did they choose, and if it's absolutely indistinguishable, then, I think you pretty much have your answer. But anyway, I know you have to go. So I think this was really instructive. I mean, I think lottery is the answer, not just in medical school, but, places like Harvard undergraduate admissions. Do we really have the arrogance to think the person who just didn't make it to Harvard was not as meritorious as the person who just made it? It is 1,600 spots, and then there's probably 20,000, 40,000 meritorious, maybe even more, 100,000 meritorious students graduating from high school every year who are Harvard material. Ben Mazer, you got to run. You're in a shared room, and
I'm in the middle of work.
Well, it's a pleasure.
All right.
Take care.
Okay. Well, it was nice talking. All right. Bye.
Bye. That was Ben Mazer. He's cut short because somebody walked into his conference room. But I think I will finish my thought. My thought is he's right about the lottery. And I think that the instance where he was criticized for his tweet is a very illuminating instance about the way in which a well-motivated push for a better and more inclusive world can accidentally push too hard and find an example that doesn't really fit and, punish someone who probably shouldn't have been punished. Those are my thoughts. So, that's it. I'm back in plenary session, joined via Zoom by Dr. Tem Bendapudi. Dr. Bendapudi is assistant professor at the Harvard Medical School. He is an expert in hematology, specifically thrombosis and hemostasis. And we're going to be talking about TTP and the greatest new drug, Caplacizumab. Dr. Bendapudi, it's a pleasure to have you here.
Thanks so much for having me.
So, when you see patients with TTP, that's something important in our line of work in classical hematology because it's a severe diagnosis. What runs through your mind when they call you in the middle of the night and say, "I see schistocytes"? What do you think?
It's a great question. I mean, I think in our training as hematologists, this is kind of one of the things that people describe as the heart attack of hematology, something we need to respond to quickly. I would say that, there are a lot of conditions that can cause schistocytes, which are these broken up red blood cells that are in circulation in conditions like TTP. But there are a number of other conditions that can cause it too. And I think one of the most important things in the middle of the night when you get a call like this is to really try to figure out if this is a real case of TTP or one of these other conditions that can look like it.
So what are those other conditions and how do you tease it apart? Yeah, when you get called.
Yeah, no, it's a good question. I mean, we have it's unfortunately a lot of conditions can look like this. Cancer can cause it, transplant can cause it, certain medications can cause schistocytes to appear on a smear. And so actually our research group, which works on TTP specifically, have developed a scoring system, a clinical scoring system that physicians can use to try to diagnose TTP in the middle of the night. But at the end of the day, you really need a blood test called the ADAM-TS13 assay to really measure the levels of an enzyme that go down severely in patients with TTP, but not with other forms of these TMA schistocyte conditions.
Yeah, and what's the turnaround time at MGH for the ADAMS-TS?
Right now, it's still 3 to 5 days, actually.
Yeah.
It's a send-out test, and we don't really have access to it in-house. There are only a few centers in the country that do it in-house because it's a rare disease, and it's actually the only thing the test is used for. So many places don't want to maintain the test in-house because of the cost and the staffing requirements. So instead they have us send it out. So we have this window of often 2 to 3 days at least where we don't really know for sure what's going on with the patient.
Yeah, and this is a common dilemma we face when you get called. There's some evidence of microangiopathy. There's some evidence of schistocytes, and the platelets have fallen, and you're not exactly sure what's going on. And so the decision that often comes across our desk is the decision of plasmapheresis or not to plasmapherese. And a while back, I spent some time and I looked up the original randomized control trials that support plasmapheresis over plasma infusion, which was the standard of care prior. There's small studies from like the 1970s that show mortality benefit. This Canadian study. So I guess in your mind, how do you decide who are those people that are going to get Plex, and while you wait for the Adams TS, and what sort of benefits you think they're deriving from the Plex?
Yeah. So, the study you're referring to, the ROC study from 1991 in the New England Journal, was a seminal study in our area. It took them 10 years almost to accrue the patients.
I see.
That study, because it's a rare disease, and it really proved that plasma exchange is superior to just giving people plasma infusion. There was quite an improvement in mortality. So in big centers like yours and where I work, plasmapheresis or plasma exchange is actually the standard of care now. We really don't just give plasma to people unless we have a very low suspicion and we're just kind of waiting for the ADAMTS13 assay to come back and the patient looks clinically very well. But I would say in 85 to 90% of high-risk cases, we're really going straight to plasma exchange.
And what is the rationale of plasma exchange? The body makes something that's targeting ADAMTS13, and you have to remove that from the body. Is that right?
Exactly right. So what causes TTP is the production of an autoantibody against the enzyme ADAMTS13. ADAMTS13 is responsible for cleaving von Willebrand factor, which many of us remember from med school as being important to thrombosis and hemostasis. Cleaving von Willebrand factor into smaller units, it's produced as a large multimer. These large multimers, when you lose ADAMTS13, can accumulate and actually cause small blood vessel clots inside in the small vascular, the microvasculature, and that can be quite dangerous. So in TTP, this autoantibody wipes out ADAMTS13, which makes the accumulation of these ultra-large von Willebrand factor multimers occur. And to answer your question, what plasma exchange is doing is it's removing the bad antibody, the autoantibody in the plasma, and then giving back donor plasma, which has all the goodies in it, right? That's going to have all your ADAMTS13. It's going to have smaller von Willebrand factor multimers in it, and that's actually curative in this condition.
And if you're in a pickle, you can just infuse the plasma and let the ADAMTS13 overwhelm the antibody.
Exactly right. So if you in a lot of centers that don't have access to overnight or 24/7 plasma exchange, it is totally acceptable to give FFP or just plasma transfusion until you can get the patient to a center where they can do exchange. But it's again in a large place, so it's kind of a large center, small center kind of dichotomy, I think there.
I see. The body is full of things that could be antigens, could be epitopes for autoantibodies. Why, in the universe of all the possible autoantibodies, we get many types of flavors. We get all the rheumatologic conditions, which is, autoantibodies against centromeres and this and that, and neutrophil this and that, and all these things that I don't care about because I'm not a rheumatologist. But we also get autoantibodies against ADAMTS13. Do we get autoantibodies to every epitope with equal frequency, or is there something about ADAMTS13 that lends itself to getting autoantibodies more than the average thing in the body?
Yeah. I think that's like one of the $1 million questions out there in our field. I'm certainly not a rheumatologist or an immunologist either. I think there are definitely certain proteins, at least in hematology, that are much more prone to getting autoantibodies. As you know, Vinay, factor VIII is much more prone to autoantibody development than factor IX.
Yeah.
Like why? It's a bigger molecule, but that doesn't really explain the whole thing.
Sure.
ADAMTS13, for whatever reason, there's a propensity to get these autoantibodies in certain individuals, and it can be quite deadly, if it's not picked up in time. So it's just one of those things, one of those mysteries of medicine.
Just like COVID toes, we may never know the truth.
Right. Exactly. We may never know.
Never know. Okay. So that's the pathophysiology. That's why we use plasma exchange. And you make another excellent point, which is you plasma exchange someone, you get them through this acute insult, and some people have durable remission. So what explains the durable remission? Why do some people flip this off, and why do some people still relapse? What's the physiology there, biology there?
Yeah, I mean, our data suggests that the relapse rate's pretty high. It's like 30 to 50% if you go out far enough. And the short answer to your question is we really don't know why people relapse. We published a study actually last year of a multivariable regression analysis, Cox regression analysis, looking at possible predictors of relapse. And we found three major risk factors. One is younger age at the time of presentation, and that's adjusting for follow-up period. So that's not just, obviously younger people, you're going to have a longer follow-up, more chances to relapse. But we adjust for that. You're still looking at a higher relapse rate. And that might be because, people presenting younger often, as you know, in medicine, just in general, have a more severe case, whatever
it is they have, yeah.
Number two is non-blood group O. So groups A, B, and AB are at higher risk. And that's because group O people have lower levels of von Willebrand factor in general. So they're maybe slightly protected. Okay. That's at least the thought.
Sure.
Kind of interesting, right? Because von Willebrand factor is the culprit in all of this.
Of course. Yeah. Runaway von Willebrand. Yeah.
Yeah, and then the third thing is not going to surprise you at all is that if you've had a previous episode and you're presenting with a relapse, your chances of having another relapse in the future is also higher.
Relapse begets relapse, yeah.
Exactly, and the best predictor of future performance in medicine is past performance. And so those are the main things that we've identified, and there are, of course, molecular immunological factors that I'm not qualified to talk about, but I'm sure that govern all of this.
I see. And then in your mind, as a hematologist that's consulting on this problem, when do you think about Vinca, steroids, Rituxan? Who do you deploy them in, and at what time point? How do you think about that?
Yeah, definitely. So I tend to give steroids to all my patients up front. There is it probably doesn't do much in most patients, but I think there is definitely a subgroup of patients who might respond only to steroids alone.
Sure. And what do you give? You give 40 of Dex? What do you give? You give like a TTP dosing?
We actually give 1 mg per kg of prednisone.
Okay.
Yeah.
Okay.
And there's this whole, no one really knows how long to keep it on for. No one knows really, what the course should be, but everyone kind of does their own thing. But for the first week or two, almost everyone will get this 1 mg per kg or equivalent of prednisone. And there are case reports of people responding only to that. Not even, it's very rare, but it can happen. And then Ritux, as you know, is a great immunomodulator. It decreases the risk of recurrence. That's been proven multiple times now in several pretty well designed studies, in my opinion, even though it hasn't been done in a RCT, in a randomized controlled trial. And the data is pretty convincing. And so we are moving more and more towards using rituximab up front, or at least during the initial presentation, rather than waiting for a relapse. Not necessarily upfront in the sense that as soon as the patient comes, but
before they're discharged. Yeah.
Yep, exactly. And I'll just say, for your listeners who are MDs out there, also in the HemeOnc area, HemeOnc field, the Ritux dosing is also very interesting because a lot of people give this kind of lymphoma dosing, 375 milligrams per meter squared, weekly times 4. It's like basically, just an ocean's worth of rituximab for a benign heme condition. Their B cell mass is much lower. They don't have the risk of resistance or mutation that DLBCL patients have.
Sure.
So I actually just give 1 gram IV times 1, and then just send them out on that. That's the rheumatologic dosing. But everyone kind of does things differently, but I don't think they need to have the oncologic dosing.
I see. So you just do 1 gram times 1. Okay, yeah, roughly a B, and regardless of BSA, you just do it. So it's yeah. I mean, for somebody with 1.73, I mean, it's just
it comes out to be close, but we don't do the repeat.
Yes, the repeat.
Back. It's kind of like
their B cells have been hit. They've been
yes. It's a rheumatologic regimen that is used relatively common. It's just to give 1 gram and their B cells. If you do peripheral blood flow cytometry on them, even a day or two later, which we've done at MGH, just to kind of take a look. Their B cell, at least their peripheral B cell compartment, is completely cleared by that point.
I see. So I guess what we're alluding to here with glucocorticoids, with Rituxan, with even some of the cytotoxic drugs that you sometimes use in these people who keep relapsing, and pheresis, is everything we're talking about is directed at the biology of the disease, either removing the culprit autoantibody or ablating the cell that's making the culprit autoantibody. That's how we're treating the disease.
Correct, and replacing the missing enzyme.
Sure, and replacing the enzyme that's missing.
Exactly.
Enter Caplacizumab. This is a different way. Is it treating the root cause? Maybe tell us a little bit about, before we get into this trial and before I blow a blood vessel in my neck because I hate it so much. Why don't you just tell us through, like, how is this supposed to work? What's the logic? Is it the same as these other things?
So exactly. So that's key. So just to take a step back and kind of talk a little bit about this drug, Caplacizumab. It's one of the first new treatments that has been generated or been developed for TTP really since the advent of plasma exchange in the late 70s, early 80s. It's a nanobody biologic agent that targets von Willebrand factor and actually prevents the prothrombotic effects of von Willebrand factor from occurring. And so what basically is happening in people who receive Caplacizumab is that the function of von Willebrand factor is being blocked. So even if they have an autoantibody against ADAMTS13 and they have these ultra-large von Willebrand factor multimers, it almost doesn't matter because the von Willebrand factor that's there can't work.
I see.
The downside, of course, is that there's a name for that condition. It's called type 3 von Willebrand disease.
Yes.
Which is when you're born without von Willebrand factor at all, or with very, very low levels. And it's an extremely dangerous bleeding condition. So the obvious
predicted
adverse
side
effect of
yeah.
Caplacizumab is bleeding and hemorrhage.
And you say it's a nanobody, which my understanding is something that comes from camels. It is a unique type of antibody that doesn't exist in anything else but in camels. It's very small.
That's correct. It's very small. It's just really, if you think about the tips of antibody has two kind of binding sites. If you just think about the tips, that's really what you're getting, those two tips. So it's a much smaller molecule. I understand my understanding is that it's much easier to manufacture for pharmaceutical purposes as well, because it's a smaller molecule.
I see. If I took you right now and I pumped you full of Caplacizumab, you think at some point you'd start to bleed?
Yeah, I think so. Yeah.
Would it be a perfect crime? Could I get caught? Do you think?
Well, yeah. I mean, I think that it would be there would definitely be blood tests to show that I had developed severe type 3 von Willebrand disease overnight.
Yes, overnight.
But if you look at the trial data, it's pretty well borne out that these patients have quite a bit more bleeding history with Caplacizumab than those treated with standard of care plasma exchange. Yeah.
Yeah. I guess one thing interesting to me that I draw the distinction is that in the causal sort of pathway of this disease, this is sort of a late event in the pathophysiology of TTP. You're not treating the autoantibody where it comes from. You're not treating restoration of Adams TS. You're preventing von Willebrands from forming very large multimers, which contributes to the final common pathway to thrombotic risk.
I mean, a key thing to remember about Caplacizumab is that it does not, unlike all the other therapies we use in TTP, it does not alter the underlying disease process.
Yes, that's what I want you to say.
I think that's an important thing to remember. It does, and this actually goes back, Vinay, to a lot of the stuff that you've done, in terms of surrogate outcome markers. It does kind of treat the number.
That's what I think. Yes.
And it increases your platelet count. Which is one of the markers that we use to monitor response to treatment. It does that very nicely, of course, because it immediately blocks the function of VWF. But if you look at hard outcomes, there really doesn't seem to be much of a difference, and certainly not a statistically significant difference. And another downside, as you may remember, even from your days in training, is when you get one of these patients, you're following that platelet count to watch them respond to plasma exchange.
Yes.
When you give Caplacizumab, the next day their platelet count skyrockets.
Yes.
But you have no idea how long then to continue the plasma exchange because their thrombocytopenia is masked by the drug. And I think that is a real concern. And in the randomized controlled trial data in the FDA approval trial and in the preceding phase 2 trial, you'll see that patients getting caplacizumab had a much higher rate of relapse as soon as the treatment was discontinued because they were underphoresed and they didn't actually receive sufficient therapy. Yeah, exactly. So it's actually a real practical concern as well, that we don't have an answer to yet.
It's such an interesting design. So you've alluded to Hercules. We got to dive right in. So I guess to the credit of the Hercules investigators, at least they're doing randomized trials in this space. That's the credit. To the detriment of the Hercules investigators, they have constructed a very convoluted trial that uses an endpoint that I don't like. It's sort of a self-fulfilling prophecy that, and let's talk through it. It's a very interesting study. So, I have a thought experiment for you before we even talk about Hercules. If I did a randomized control trial and in one arm, we just do what we're doing now. In the intervention arm, I build a glitch in EPIC, and all it does is adds 50 to the platelets. I've done nothing to the biology of TTP. I've just made a computer glitch, and whatever you think the platelets are, I've added 50. So this is my hypothetical randomized trial. What do you think might happen? Well, one, after you start, when you get these patients, let's say my glitch only goes into effect the moment you start pheresis. You start pheresis, my glitch starts. Your platelets are going to be higher in my EMR glitch arm than they are in the control arm. So you're going to stop pheresis sooner. I suspect there's going to be more relapse in that arm because you're not treating the disease enough adequately. Will you have more bleeding? Potentially, because you're going to have some more runaway TTP, and you might have some sort of thrombosis and bleeding on the back end, but I don't know if you'll get that. The reason I think about it this way is now let's talk about Hercules. Hercules is a randomized controlled trial of caplacizumab, and the primary endpoint, I want to double check, the primary endpoint is time to normalization of the platelet count. And okay, why don't I let you talk about it? Yeah. So
Sorry.
Yeah.
No. I everything you said is exactly correct. And, it's a very cleverly designed trial in the sense that, they chose a surrogate endpoint that, they could not help but meet.
Yes.
Whether that surrogate endpoint is really predictive of any improved outcome in TTP is a totally different story.
Yes.
But it is, there's no question that they were going to meet this because they're essentially applying a Band-Aid to the problem.
Yes.
Masking the thrombocytopenia and then saying, okay, declare victory and get out. So that's not really, but unfortunately the follow-up data is not really, encouraging that that's a good way to solve this problem.
Yeah. And I guess my question for you is caplacizumab and my electronic medical record glitch experiment, is there anything in the data that would show that they are indistinguishable? In other words, what happened in this trial that's different than if you just inserted an electronic medical record glitch?
It's a great thought experiment because to be honest, I don't think there would be a discernible difference there.
Yeah.
I just want to caution, caution your listeners as well. We don't know the long-term impacts of caplacizumab. On the one hand, you have bleeding. It could be, you have relapse. It could be damaging. On the other hand, I also have to be open to the possibility that
it does help. Yeah.
That it does help long term. That there could be improvements in neurologic outcomes or things like that that are subtle, but that we're not picking up. That come from this uber blockade of the VWF clotting pathway. But that remains to be seen. And as you know, the burden of proof is really on the investigators to show that, not on people who think the drug should be used with caution.
Yeah, absolutely. And I think that would have been a great study to do a randomized trial powered for those long-term outcomes. You'd need bigger sample size, but it would really show if this is actually worth its salt. So absolutely. The studies, both Titan, which is a preceding study, and I believe Hercules as well are also another concerning aspect, just kind of alluding to what you just said, is that not all the patients in those two studies had confirmed TTP, had confirmed severe MTS13 deficiency. So in some cases, they may have even been treating patients that didn't have, true TTP. That's also of concern. We don't really know. It makes the results harder to interpret. They don't report what percent had actual TTP. I think I missed that part.
They do. It's surprisingly low. I believe in Hercules, it's only like 80 5% or 80% had confirmed severe MTS13 deficiency.
So what do the rest of the people have? They have like HUS. They have tissue microangiopathy. What do they have?
You can imagine they have. So the other 20%, and I'll get that number, but that other 20% have other forms of TMA, right? They have forms of TMA that look like.
You're right, 85%.
85%, and so they either don't have an MTS13 assay at all, or the MTS13 is not severely deficient. Now, what does that mean? Yeah. Well, if you have a non-TTP form of TMA, like we talked about at the beginning of the podcast, none of those are things you want to have. They all have to do with cancer, transplant, severe drug reactions with high mortality. In our data set, patients with non-TTP TMAs, we have like a 30-40% mortality in 90 days. So you can imagine that if those patients are accumulating in the plasma exchange arm, this is a tiny study, right? Sure. If you get a couple more of those patients in the plasma exchange arm than in the caplacizumab arm, it can look like caplacizumab, at least for mortality benefit, when we really incorporated these patients who have non-TTP TMA into the control arm. And they don't report really, the authors don't report really where those patients fell into either of the arms. So we really have no way of evaluating that.
Oh, that's fascinating. That's a big problem. I mean, I guess it's a double-edged sword. On the other hand, if they waited for the diagnosis, they would, one, lose market share, and two, maybe they would believe they'd lose the window where the drug would work. So they got to treat when you don't yet know they have TTP. But I'm curious, in your experience at MGH...
I'm sorry.
No, they did report it by arm.
They did report it in Hercules. I don't think they did in Titan. So I want to make sure that is corrected. And actually, there were slightly more in the caplacizumab arm than in the placebo arm.
I see. So it may cut against them too. In your experience at MGH, when you deploy pheresis for presumptive TTP, what % of the time do you find the ADAMS-TS is less than 10% on the back end? I mean, we all have to do some pheresis in people who comes back and it wasn't low.
Yeah. We actually did a study on this, published it a couple years ago, and looked at really how many people, in our system, actually I have the results here, in our system were so it's very common actually for patients to come in and get kind of misdiagnosed with TTP. They're thrombocytopenic and they look like they have a TMA, like schistocytes on the smear.
Yes.
And what happened in the past is that we end up giving these patients pheresis, because pheresis is actually a relatively not totally benign, but relatively benign therapy. And if they get a couple rounds of pheresis while we're waiting for the test to come back, it's no big deal. But within the group of patients who are getting, who look like the suspected TTP, who get to the point where they're actually getting pheresis, something like a third of them, or even 40% are kind of like non-TTP patients, or misdiagnosed, and they get a couple rounds of pheresis. So it's not a rare thing, at least in our system.
Yes.
And we have a lot of, we're a big hospital system with a tertiary care center, quaternary care center, so you can expect this might happen even more frequently in the community where maybe there's less expertise and familiarity with these rare conditions. In any case, the problem is, I think, with caplacizumab, which is the corollary to what you're saying, is that someone comes in with thrombocytopenia, they don't have TTP, but then they get caplacizumab because they're misdiagnosed with TTP, which is a common occurrence. Then, now you've given someone with thrombocytopenia type 3 von Willebrand's disease, severe von Willebrand's deficiency on top of it. So you're getting yourself into a real, potentially dangerous situation. And that has not been, I think, adequately addressed in the real world data.
That's an excellent point. And I guess related to that, if one gives it for the wrong reason, one might not see a platelet bounce. The platelets might not come up.
Absolutely, they won't. They won't.
Yeah.
And then hopefully those patients are getting MTS13 testing, and they'll come off of the
Plex.
The Plex pretty soon, or caplacizumab for that matter. But yeah, it's certainly a concern.
So some might say the answer is to give him more caplacizumab, but that would be the wrong answer.
Yes, some might say that. I do not think that would be the right answer.
So I have something that just came hot off the press. It's the guidelines, and here's what they say: give it. What is up with these guidelines? What's going on here?
Yeah. So I think you're referring to the guidelines from the International Society for Thrombosis and Hemostasis, ISTH guidelines, that were recently published. There are two parts of the guidelines. There's a diagnostic part and a treatment part. Both were written with caplacizumab in mind, and if you look at the guidelines, I think there are definitely some guidelines can be very helpful, but they also need to be taken with a grain of salt.
Yes.
Often. I think there are some areas of concern for sure with what they're recommending. First, they talk about taking the patients with a really high pretest probability of TTP,
Yes.
and giving them caplacizumab. And I would point out, first of all, that there is no way of actually determining the ultra high risk pretest probability patients. I mean, they're talking about greater than 90% pretest probability, and we don't have any way of determining that. Even our scoring system, which I think is probably thanks. Definitely, the most widely used, if not one of the most widely used,
Yes.
if not the most widely used, is our high risk group only goes up to 82%, 62 to 82%. There's a range.
Yes,
It's not really.
It's not over 90. Yeah.
It's not over 90.
Yeah.
And so, the idea that you can identify these patients accurately and then target caplacizumab to this group of patients with the ultra high risk,
Yes.
I think is fantastical.
Yes.
The other thing is, once you give it, this is a drug, and I'm sure we'll talk about this later, but
Yes.
the minimum cost is $270,000
Yes.
per course.
Yes.
That raises concerns already, but you're giving the drug practically upfront, and you're not even checking first to see if these patients are responding to the standard of care treatment, which is much cheaper. I have an issue with that as well. I don't think that is wise, particularly since caplacizumab has some pretty severe potential side effects.
Yeah, I mean, I guess I would say in an alternate universe where the FDA said we're going to approve drugs for TTP that improve the quality of the life of somebody with TTP, their downstream side effects and harms of TTP, this drug wouldn't even be approved. And so for it to be in the guidelines based on this data really troubles me. It almost makes me concerned that the guidelines somehow have been captured by the maker of caplacizumab. It's as if caplacizumab makers wrote the guidelines themselves. Of course, that would be a ludicrous proposition.
Right, which I'm sure has never happened.
Never happened in the history of medicine. Yeah.
You touch on a very important point. There's something that happens in these rare hematologic conditions that will not happen in cardiology or oncology or other areas writ large. Because what companies like Ablynx which has now been purchased by Sanofi, the manufacturer of caplacizumab, what they can do is such a small field. They can actually approach and kind of recruit, for lack of a better word, practically all the big name experts
Yes.
in that field,
Yes.
and have them already kind of ready to go and primed to support the use of this drug. And support it to the FDA. For example, the FDA doesn't have expertise, internal expertise in TTP. They have to refer out to these expert committees, which it's quite practical for a company to recruit all the experts, like I said, in a small field like this. And so what you see has happened is the FDA has approved. Let me just first of all talk for a moment about before coming back to guidelines, just about the FDA approval. If you think about what FDA approval means, safety and efficacy. The FDA has to ask experts in that area for a recommendation as to whether the drug meets those criteria or not. And the reality is that, at least in my view, efficacy is almost certainly not there, at least not in a real way, because all it's doing is treating that number, increasing that platelet count. And then safety, we can debate, but the truth is that the patients in receiving caplacizumab in the randomized controlled trial data, which is the highest quality data we have much higher bleeding rates and severe. Well, I'm talking things that you don't want to have, right? Like abdominal wall hematoma, hematemesis, hemoptysis, GI, upper GI hemorrhage, lower GI hemorrhage. They even had a case or two, I think, of intracranial hemorrhage that did not occur in the control placebo arm. Yeah. In the control arm. So these are things that you have to ask yourself, well, how was safety really evaluated? Yes. How was efficacy really evaluated?
Yes.
Then coming back, I think to the guidelines, what happened is very interesting. the Hercules trial it talks about caplacizumab reducing recurrences of TTP. And, what does that mean? Well, traditionally, if you and I talk about recurrence of a disease, we're talking about basically someone who's doing fine, who's cured after a bout of the disease,
yes.
and then come back in with another episode, right?
Yes.
I mean, that's what most people would think of.
Yes.
However, in TTP, it's extraordinarily common. 40 to 50% of patients with TTP will have what we call a recrudescence or an exacerbation during treatment with plasma exchange, which after they've been in a hospital maybe only a couple of days, their platelet count will go up and then it'll start coming down. During the acute episode, it's extraordinarily common, it's clinically irrelevant, and it's something we treat through, and it's just something that happens. And I never, as a doctor who treats these patients, I never really thought much of it. Well, what the folks who kind of basically wrote the caplacizumab studies have done is they got together, I believe it was a year or two before the Hercules trial was published, and not at the bidding of any professional society or any, or the American Society of Hematology or anyone. They kind of came together and developed their own quote unquote consensus guidelines or consensus definitions for TTP. And within these consensus definitions, they actually lumped these routine exacerbations or recrudescences that happen with relapse under the umbrella of recurrence.
I see.
Right. So now recurrence is defined as either having a real recurrence, which is a relapse, or one of these routine exacerbations. And once you have an endpoint that's called recurrence, you can, with those two components in it, you can very easily say that caplacizumab diminishes TTP recurrence, even though I think in any normal medical understanding of the term, it certainly doesn't.
Oh, that's a terrific point. I did not.
It's a very interesting. I'm sorry, I'm sorry for your listeners if I got a little bit too into the weeds on that, but it's a very important point for people who want to know about this field to understand.
No, I'm just angry that I didn't. That was one thing that I've not picked up. So I read it really closely. We did a podcast on it a while back. That's a point I didn't pick up. That's a terrific point.
I'll send you a paper. It's a JTH paper, consensus definition guideline, consensus definitions in TTP. It was published right about a year before Hercules, and that's actually cited in the Hercules study for their in their methods for their patients, for their study. So it was almost tailored. Those definitions were almost tailor made to support Hercules.
I see. So let me see how it plays into this. So in the secondary outcomes, they say during the overall trial period, during the 28-day follow-up, in which patients were no longer receiving caplacizumab or placebo, 12 patients in the caplacizumab group as opposed to 28 patients in the placebo group had a recurrence of TTP, which is a lower rate of recurrence. All recurrences in the placebo group occurred within 30 days, and all at the end of daily plasma exchange. I see. So in other words, the difference that they're claiming may be simply due to the fact they're masking this well-observed phenomenon. Maybe.
Absolutely.
Yeah.
I think for people who've read these studies carefully, they have a composite surrogate endpoint that, well, let me put it this way. They have a composite endpoint that's driven almost entirely by a reduction in these clinically meaningless exacerbations. That's almost certainly the case. Once you look at hard outcomes like mortality or relapse, people with caplacizumab aren't doing any better, or they might even be doing worse.
Interesting. I think you made a number of great points. The point I want to echo is that, there's a reason why the industry has shifted all its focuses to these rare diseases. You can develop a drug for a rare disease, hit a surrogate endpoint, and then pretty much buy your way through all the KOLs, and then you have both the product on the market, and you can charge whatever you want. You can make a lot of money, and insurers will have a hard time pushing back because the net budgetary impact of a TTP drug is not going to blow their wallet out. It's just going to be another sort of line item on the big budget. So there really is very little downward pressure to regulate these rare disease spaces.
Absolutely, and I think, to be honest, I've been very honest and vocal about this. I think the cost, the set price for this agent is embarrassing.
Yeah.
I think we should talk about that for a moment, because really the price is set at it's about $7,800 per daily injection, per daily dose, and it comes out to be for a 30-day course about $270,000. The Hercules study trial actually studied people up to 56 days. So you're talking $450,000 for a disease for which there is a curative treatment with standard of care currently, it's a no-brainer to question the cost effectiveness of this approach. And in fact, we just actually had a manuscript. We had a manuscript recently accepted for publication in which we analyzed the cost effectiveness of caplacizumab relative to standard of care. And I just want to, without boring you too much about it, I mean, basically we found that caplacizumab would have to be more than 80% cheaper than it is for it to be even marginally cost effective. And this is in a study where we were really stacking the deck. We really used a very conservative set of assumptions to try to stack the deck in favor of caplacizumab. And also, by the way, I just want to acknowledge my colleague at Yale, who's really spearheaded a lot of this work, George Joshua, who's really done a wonderful job with this analysis. Yes. But, at the end of the day, as George and I actually joke sometimes, he's kind of like using a scientific method to prove to people the sky's blue.
Right.
It's like, it's not really that surprising that, like I said, a drug costing $270,000 to $450,000 per patient in a disease that is curable now with current standard of care might not be cost effective. That's not really a surprise. And so we've really had a lot of trouble, I think, justifying the use of this agent. I would also say that when you look at, and as I said, we used very conservative assumptions and stacked the deck in favor of caplacizumab in this study, in our analysis. In fact, we don't even account for, in the cost, we account for none of the costs that are associated with increased bleeding from caplacizumab. I see. So if you need a scope or, an operation because you're bleeding internally or have a GI bleed from
not adding that in.
That's not added. And those rates are extraordinarily high. So,
and you're giving them some, you're attributing some quality adjusted life year benefit to the drug that they have not yet even proven. So you're giving them that benefit too. How many qualities do you give the drug?
I have to actually look back at the exact number, but the ICER is something like $1.5 million
per quali. I see.
So you must with the willingness to pay of less than $195,000.
Yeah, get out of here.
This is already like 6 times more than almost 7 times more expensive than it should be. Again, if anything, the ICER is going to be even higher.
I know, that's what I was going to say. It's at least, I think the real ICER, it might be in the 10 mil, 100 mil. If it doesn't actually improve quality or quantity of life, it might be infinite, so yours is the lower bound ICER of one, and that tells you that this drug is horrendously priced. It's criminally priced.
Yeah, and we're seeing a lot of that now. At least I know you guys see it in onc too, but on the benign heme side, we're seeing that more and more. There's another drug, the porcine factor 8, which is used in people who Obizor, exactly.
Obizor.
They dose that drug at $4.50 a unit. So basically, if you take a 70 kilogram person and you want to treat them, it's like $65,000 per infusion for the first dose. It's $65,000.
So that's a lousy drug. The data for
drug where there's a standard of care treatment that works.
Obizor, and also, what's the data for that? That's even more flimsy than Hercules.
There's no
real. It's just all. It's all logic and I
remember
you had a refractory with tons of inhibitors and you had to give it.
Exactly. It would have to be like last third line or something.
Hemophilic with tons of inhibitors. I think the other situation that we run into is the good folks at eculizumab who want to put the eculizumab in my breakfast sandwich. They're like, oh, did you see there's a new case series of 4 people with post-transplant TMA and they did well with eculizumab.
You're absolutely right. And the eculizumab has been extremely aggressively marketed for off-label use. But let me say one thing in favor of eculizumab, and you may be surprised when I say this. I actually like eculizumab because, for the only reason that it actually does something.
It does work in PNH.
the drug does something that we don't have another drug to do right now. And if you have one of these complement-mediated conditions, PNH, atypical HUS, I've actually used it in very severe cases of autoimmune hemolysis. And gotten good results. At least you're paying a ton of money, but the drug does something. We can have a debate all day about drug pricing, but I think everyone can agree if the drug doesn't do anything caplacizumab, it should be priced. There's no reason to price it like that high. And so I think that's where my concern is I'm just trying to keep it very limited and just say, hey, we all should agree that drugs that don't do much should not command that kind of pricing. Honestly, I would be embarrassed to try to market a drug with that price, like caplacizumab at that price.
I think that's well put. Even in today's polarized world, I hope that everyone can agree if the drug doesn't make people live longer, live better, we should not be paying $200,000 for 1 month supply of it.
Now, the people, keep us all honest here,
Sure.
the people who market and sell caplacizumab would claim that plasma exchange is a condition that requires a central line to be put into the patient.
Yes.
And that can be associated with complications, and pheresis can be associated with complications too. Mostly allergic. Our data, which we published last year, suggests there's mostly allergic reactions that people get. But occasionally there can be more severe, very rarely, there can be more severe reactions. But they would argue that they're preventing that from happening because caplacizumab doesn't need line placement to go in. But I would argue, that's a pretty marginal benefit, particularly when you factor in the bleeding complications.
And also that they're not selling this drug in lieu of Plex. It's in addition to Plex, right?
Right, exactly.
Yeah, it's in addition to Plex.
Sorry.
It's just the delta of like 1 extra day or 2 extra days of Plex.
You hit the nail on the head. Sorry, I should have mentioned the point. They even in their own protocols, it requires the line to be placed and people to get plasma exchange. It actually, so in the Hercules trial, the average number of exchange treatments was like 5. So they're still getting 5 exchanges, which is probably not enough because they're relapsing. A lot of them are relapsing.
Yes, that's the real problem.
And then there's been this much kind of talked about study out of Germany, where they took 60 patients with TTP and treated them with caplacizumab. It's called a real world experience. That's how they build it. Mm-hmm. And what's amazing is in that experience, which they build is the authors conclude, by the way, a highly conflicted author line about first and last author both receiving money from Sanofi and that kind of thing. But they bill it as this real world experience, and their conclusion is that all patients, it should be standard of care in all patients to give them caplacizumab up front in TTP. But what they found in that study, which is amazing, is that they actually had to use, I think, 10 or 12 pheresis treatments in those patients. They got maybe it was 9 pheresis exchange treatments, which is in our system the average is like 11. So they're barely changing that number.
Right.
And their hospital length of stay was 18 days.
18
whereas
days.
In our data it's only 12.
Yes.
So they're actually
extending the stay to give the caplacizumab. Yeah.
It's unclear what's
so
even going on.
These uncontrolled studies of 60 people. When I trained, we used to call those shitty studies. Now they call them real world evidence. So it's just, a lot has changed. A lot has changed. A lot of power branding.
This is what we're dealing with,
Yes.
and I think, but there's a lot of money at stake, as you know, Vinay, and people will push this drug, I think, as long as they think they can make a lot of money on it.
Yeah. So I think our time has run out. So I guess last word, my last 2 cents on this drug is, and then I'll take your last 2 cents, and you may disagree with me. I just don't think it has a use. I mean, I just do what we were doing before, and until there's some new data that changes me, I'm not going to use it. I think some people pushed me and they said, well, what about like a Jehovah's Witness patient who comes in with TTP? And I was like, I guess. Or like if the asteroid is coming at the Earth and going to hit the Earth. And I mean, like, okay, there's scenarios where, okay, maybe I'll give a caplacizumab dose or here or there. I don't know about you. So where are you going to use it, if at all?
I think there are two. I think there are only 2 situations where I would use caplacizumab. One is maybe 3. One is in as a temporizing measure, possibly as a temporizing measure, if you for some reason cannot give FFP, patient is allergic, anaphylactic,
I see.
and you don't have phoresis available.
You can't plex.
This is
I see. Right.
This is a third line. It's a third line.
Temporizing measure.
That's number 1.
Okay.
Or of course, if COVID mutated and wiped out all the phoresis.
Well, I would actually say let me add to your hierarchy. So 1 plex, 2 FFP. 3, call him an Uber, and 4 caplacizumab. So it's the 4th temporizing measure. Yeah,
right. Yeah. Well, it would be cheaper. It literally would be cheaper for you to chopper most of these patients.
Yeah, of course. Yeah.
From rural Massachusetts, where I am,
yes,
or rural New England, to Mass General to get free
to chopper them.
Give them caplacizumab.
And they get the difference in price, which is probably another $50,000 in their pocket. The chopper ride and a little bonus.
Yeah, they get to ride a helicopter. So that's one. That's one. Another would be in highly refractory cases that you just cannot get out of the hospital.
Yes. Okay.
We sometimes, very rarely will have cases where people are freezed for 3, 4, 5, 6 weeks. But even then,
I give Rituxan. I would give him Rituxan and steroids, and maybe give him some Vinca. Yeah.
We're giving the Rituxan. Yes, you're absolutely. We're moving up the chain in terms of autoantibody treatment. But basically, even then you can put in tunnel line and do outpatient pheresis. We actually do that non-infrequently, so they do get to go home. They have to come in every other day or whatever.
But it's like dialysis.
So it's not ideal. I get that. So that's another case maybe. The final thing I think is in ultra refractory cases where patients are deteriorating on exchange, but that is, you already have to start exchange to see that. You need to use exchange up front, and those cases are exceedingly rare.
Yes.
I mean, like low single digit % in a disease that is extremely rare. So it's hard to know what the real role of this agent is, and at the cost it currently is at, I think it's hard to justify.
That's well put. Dr. Bendapudi, thank you so much for joining us about this drug that it makes me get an aneurysm in my head when I was reading about it. And I think you taught me a couple of things I didn't know, so I'm really grateful to you. Thanks so much for doing it.
Oh, thank you. Thank you so much for having me on.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.